Good evening, everyone. So welcome to the Canadian Breast Cancer Network's webinar for this evening. We're just going to give a minute or two for everyone's connections to start syncing up. We have over 500 participants this evening, which we're really thrilled about. Obviously, you're excited to hear from Dr. Jean Seely, so we will not take too long to get started. Just want to make sure that everyone's able to connect, and I see many people coming in, so hopefully you can hear me speaking. If you're just joining us, welcome to the Canadian Breast Cancer Network's webinar this evening. And we're just giving everyone a minute or so to get their technology working before we get started, so that you won't miss anything. Good time to set your levels and make sure you can hear me. Hopefully you can hear me, and you should be able to hopefully see the screen. Again, welcome for those just joining us. We're so pleased to have everyone joining us this evening for our webinar. Just going to give, I think, one more minute. We're about 1 minute after 6 here, and then Kathy and Dr. Seely will get started. Okay, so I think hopefully it's slowed down a little bit. So I'm hoping everyone who is trying to connect is able to connect. I'm sure we'll have a few more people joining us as we continue the webinar. But on behalf of the Canadian Breast Cancer Network, I'd like to welcome everyone to our session this evening, Screening After Breast Cancer. I'm Jen Gordon. I'm the Director of Operations with the Canadian Breast Cancer Network. Before we get started, I'd just like to do a couple quick housekeeping items. So the session is being recorded this evening, and it will be posted on the CBCN website later on this week. I'll make sure to pop the link into the chat, so you'll be able to see what page that will be on later this week. We also have pre-recorded webinars available for viewing there as well, and some of our questions and expert sessions. And I will also add a link to the chat where you can register to be notified of any upcoming webinars as well. I would like to extend our sincere appreciation to our sponsor this evening, Bayer, who supported this webinar through an educational grant. So thank you, Bayer, for your support. And the format of this evening's session will be a presentation by Dr. Jean Seely, followed by about 20 minutes, depending on how long we have, of questions from the audience. As I mentioned, we have about over 500 participants registered today, so we unfortunately will not get to everyone's questions, but we'll try to sort of pick some high-level ones that address multiple questions. And then we were talking about maybe we'll have to do a follow-up session, so we'll see how that goes. I would now like to welcome our host for this evening, Kathy Amandalea, who is the chair of the Canadian Breast Cancer Network. Kathy has worked with CBCN for many years, over a decade, I think, at this point, Kathy, and really understands from the first person lived experience what it's like to be diagnosed with breast cancer, and really the importance of then being able to understand what screening should be done after that. So Kathy, welcome.
Thank you very much, Jen. Welcome again, everyone. Thank you for joining us today. I'm so pleased to welcome and introduce our expert speaker, Dr. Jean Seely. Dr. Seely is a leading breast radiologist at Ottawa Hospital. She is professor of medicine in the Department of Radiology at the University of Ottawa. She is also head of the breast imaging section at the Ottawa Hospital and is the regional breast imaging lead for Ontario Breast Screening Program in the Champlain region. She is the president of the Canadian Society of Breast Imaging and also serves on the editorial board of the Canadian Association of Radiology Journal. Dr. Seely, thank you so much for joining us today and sharing your knowledge with us.
Thank you so much, Kathy and Jen, for the invitation to speak. I'm going to share my screen. Just can you confirm that you can see my slides without the notes? Okay, thank you.
We can, yes.
Thank you very much. It's a wonderful opportunity for me to be able to have the chance to share some information that really I think is empowering to women who've had a personal history of breast cancer and to those who are involved with helping them. And I speak on behalf of many in the healthcare team who strive to provide this information to all men and women in Canada. And I also want to acknowledge the hard work that they're doing during the pandemic, which has made our lives all more difficult with
I'm just going to interrupt for 1 second, Dr. Seeley. So I have the notes that have popped up on my screen. So we can see the notes right now. We might need to just reset it.
Thank you very
Apologies.
much. No problem. I'm going to just change this and okay, is that better?
That's great. We can see the full screen now.
Oh,
Apologies for
thank
the
you.
interruption.
No, that's great. Thanks for doing that. So these are my disclosures. I have no financial disclosures other than some compensation for speaking to you today. And I am the principal investigator for Ottawa, which is a non-paid position. So my objectives are to have you understand the different types of screening that are used after a breast cancer diagnosis, and for you to be aware of the frequency of screening that is recommended for all women with a personal history of breast cancer, and to be aware of what type of screening best fits certain patients. So we all know breast cancer is very important. It's the most common cause of cancer in women and the second leading cause of cancer death in women after lung cancer in women older than 55, but the leading cause of death in women under the age of 55. 1 in 8 women in Canada will develop breast cancer in their lifetime, and 1 in 31 women will die from their breast cancer. So I don't have to speak to any of you about the incredible anxiety and awareness that we have about breast cancer. And you know, it's available in the public media, but we want to drill down to understand better, and which I think helps alleviate some of the anxiety. So the benefit of early detection of breast cancer, if it's located only in the breast, the 5-year survival rate from breast cancer is almost 100%. It's a very different diagnosis than if we have a late stage diagnosis where the breast cancer survival drops to 50 to 60%. Fortunately, in Canada, before the pandemic, 60% of cases are diagnosed at early stage. And the overall 5-year survival for breast cancer is about 87% because of the later stage diagnosis and some other factors that mean that the survival is not as good as 90%. So survival from breast cancer is improved with early detection and better treatment, and depends very much on the stage at which it's diagnosed. So if we have an early stage diagnosis, which is called T1, N0, M0, so no metastatic disease and no spread of the cancer to the lymph nodes, that is close to 100% survival. But we see the marked decrease the later the stages, so that women who have a spread at the time of diagnosis have a 5-year survival that drops to 20%. So the tumor size is really helps determine the stage at which they're diagnosed. And when we look at the early stage, it's between 0 and 2 centimeters. T2 to 5 centimeters, T3 greater than 5 centimeters. And if you look at this diagram, you can see that that's the shape of a line is a T3 tumor. And we diagnose these tumors, the larger ones with physical exam and the smaller ones with a clinical breast exam from a doctor or a healthcare professional. And the mammogram can actually diagnose it the earliest when it's a centimeter or less. And that's where we're always striving to identify a cancer that is too small to feel, that is, usually 10 millimeters or smaller. And this is a very good example of a small cancer found on a screening mammogram. Now, when we wait for it to be palpable, it's usually larger, but we can often see that it is visible on this case where it was missed, where the patient did not want any treatment. You can see that the growth is slow over the 2 to 3 years, and then it becomes clinically evident. And this now is a larger stage. So I want to emphasize that the difference between screening, which we also call surveillance in women who've had breast cancer, is that there should be no symptoms of breast cancer. And when we look at women who haven't had any breast cancer and look at the mortality from breast cancer over the past 40 years, before we started screening, there was no change in the mortality from breast cancer. It was a flat line from 1960 to 1990 about, but by the time we started screening in 1989, the breast cancer mortality started to drop. And this is an amazing success for us in Canada and around the world, where you can see that the breast cancer mortality has dropped, has improved by 48% in Canada. So that's a huge success. And we can see that this correlates with the number of cancer deaths avoided. So in Canada alone, up until 2012, we've avoided over 32,000 breast cancer deaths from screening, which is fantastic. Now that means we have a lot of women who now are living with a personal history of breast cancer. In the United States, they estimate 3.8 million women with a personal history of breast cancer. And if you translate that to Canada, it's about 10%. Every year, we have new breast cancer diagnoses, and last year we had 5,400. So we keep increasing the number of women who are living with breast cancer. And I know very, very well, probably not as well as most of you, how high the levels of anxiety, fear, and worry are about getting a recurrence or a new breast cancer, or getting metastatic disease, or dying from your breast cancer. And this is what we really are striving to avoid. Now, if you look at high risk for breast cancer, the threshold for us to define a high-risk patient around the world typically is a lifetime risk of getting breast cancer of 20% or higher. That's 1 in 5 chance of getting breast cancer. And I told you average would be 1 in 8. And if you look at women who have had prior breast cancer treated by a lumpectomy without tamoxifen or with tamoxifen, they have a lifetime risk that's higher than 20%. So they meet the threshold for high-risk screening. It depends on their age. So when you get older than 66, that risk decreases to below that threshold of 20%. And women who've had a mastectomy are below that threshold for high-risk screening. Now, these are the specialists who are going to help reduce or prevent recurrent disease. And I'm not going to get into the details because the oncologists, surgeons, and radiation oncologists all have different strategies to treat the breast cancer to minimize the risk of recurrence and to optimize the survival. My job as a breast radiologist is really to reduce the late stage of a new or recurrent breast cancer diagnosis in people who have a personal history of breast cancer. So how do we reduce a delayed diagnosis of a recurrent breast cancer? And this is where we really talk about screening. So as I mentioned, the size of breast cancer detection really has an impact on outcome and survival. And we also know that women who are at later stage not only have a reduced survival from breast cancer, but they have a higher rate of complications from their treatment. They're more likely to have it spread, their cancer spread to their lymph nodes, and to require a full axillary lymph node dissection, resulting in the complication of lymphedema, swelling of the arm after the surgery, which occurs in up to 1 in 4 women who undergo that kind of treatment. We also know that mastectomy, having the whole breast removed, is much more likely for a later stage diagnosis. And it's been shown with psychological studies that women do better when they can retain their breast with a breast conservation surgery. So we see the benefits of early stage detection. So when you look at somebody who has had a personal history of breast cancer, what is the recommendation for screening? So the very basic standard is annual screening mammography. And this is recommended by all of the major imaging, radiology, and oncology associations around the world. And that has really been shown to be effective at detecting early stage second breast cancers in breast cancer survivors. The majority, when they're screened with mammography, are either stage 0, which would be DCIS, or stage 1 cancers. And this was a study of over 2,263 patients looking at what happens with survival when women are found with screening mammography to have a recurrence as compared to clinical breast exam. And they showed that the survival was improved by between 17 to 28% if the recurrence or the new cancer was found by surveillance, which is equivalent to screening mammography. And they calculated that this could reduce the number of deaths over 10 years by 5 to 8 people just performing screening in 1,000 patients. So that's really compelling news of why we should be doing screening for all women who've had breast cancer history. And here is an example of a woman who had bilateral surgery. She underwent a right breast conservation surgery for a small invasive ductal cancer in her right breast. And at the same time, she had a reduction mammoplasty on her left breast. So this is the right breast that was treated and the left breast that was not treated. And you can see that in 2013, and these, I'll blow it up here, you see that there are 2 new breast masses that are demonstrated by the red circles in the left breast. They were new, they were not seen the year earlier, and that led to ultrasound. And ultrasound of those 2 masses found that one of them was a cyst, which was benign, nothing to worry about. But the other one was a mass that looked very suspicious for malignancy. This led to an ultrasound-guided breast biopsy, which was diagnostic for a carcinoma that was under 10 millimeters. So very early stage diagnosis, which really helped this woman with personal history of breast cancer survive again a second breast cancer. Now the problem, and I think many of you are aware of this, is that we don't have the same needs for, not all screening fits the same people. And we can't assume that everyone is the same and that screening mammography works for everybody. And we know that the post-op appearance on after surgery is challenging. We have what's called architectural distortion, where we have indrawing of the tissues, which is from the surgical scarring, which makes the job of the radiologist much more difficult. We have staples from the surgery, we have skin thickening, and so it can really reduce the sensitivity of the mammogram for detecting recurrent disease. This is a study where they compiled a whole bunch of studies to look at women who had been screened, who had a personal history of breast cancer, over 58,000 screening mammograms, and they compared them with women who had no personal history of breast cancer. And they found that the sensitivity of mammography in women with a personal history of breast cancer was much lower, 65% sensitivity in women with a personal history of breast cancer as compared to women who did not, with a 77% sensitivity. The specificity was the same, but the interval cancer rate, which means that the cancers that developed in between screens, was twice that, more than twice that of the women who did not have a personal history. And the sensitivity was even further reduced in women with extremely dense breast tissue, where almost half of the cancers were not diagnosed with a mammogram. So let's talk about breast tissue density. And I think it's a very important concept to be aware of. Breast tissue is composed of fat, glandular tissue, and fibrous tissue. Fat is dark on a mammogram. It allows the X-rays to go through it very easily, but glandular tissue and fibrous tissue appear very white, and they block the radiation beams, and they look very similar to cancers. And when you have more glandular tissue and fibrous tissue present, the breast tissue density is greater. The problem with dense breast tissue is that it does two things. One is it masks cancers on the mammogram. That means it hides them. And the second is it increases the risk of breast cancer due to probably the increased glandular and fibrous tissue, which are thought to predispose to breast cancer. So graphically, you can see that as the breast tissue increases, so does the risk of breast cancer. And at the same time, the sensitivity, the ability of the mammogram to detect the breast cancers is decreased. So what about the risk of breast cancer? So it is an independent risk for breast cancer, and women who have the most dense breast tissue have a 4 to 6 times higher likelihood of getting a breast cancer than a woman who has the least dense breast tissue or fatty breast. And fatty is a good thing in this regard. Overall, the density has a twice, the average dense breasts are twice as likely to get breast cancer than non-dense breast tissue. And this risk is similar or even higher than having a mother or a sister with breast cancer. So it's a very strong risk factor. We also know that because of the white appearance of the dense breast tissue, this can hide breast cancers. And about 45% of breast cancers are associated with calcifications or tethering of the breast called architectural distortion, which allow us to diagnose it on a mammogram. But the other cancers that do not have that appearance are often hidden by the breast cancer, by the dense breast tissue. So we grade breast tissue density according to 4 different scales, 4 different categories. BI-RADS A, which means fatty replaced. BI-RADS B is scattered fibroglandular tissue. BI-RADS C is heterogeneously dense, and BI-RADS D is extremely dense. So the C and D are considered dense. And if you look at what they look like on a mammogram, you can see that the fatty replaced breasts are very dark, quite easy to see a cancer, and the scattered fibroglandular tissue a little bit more dense, but still quite easy to diagnose a cancer, whereas C and D have very much increased glandular tissue, and the loss of sensitivity in the extremely dense category is 50%. So it really has an impact on the ability of radiologists to diagnose cancer. So overall, about 75% of women in their 30s have increased breast density. 25% of women in their 70s have increased breast density. Overall, about 40% of women have dense breast tissue. We know that density can diminish over time, but we know that women whose breast density does not diminish over time are more likely to be diagnosed with breast cancer. And it appears to be related to genetics. So twins will often have the same breast tissue density. So it's a genetic factor. And there is some influence with dietary factors as well. So what we have with a fatty breast, category A, is it's very easy to diagnose a cancer. This is a small cancer, it's under 1.5 centimeters, and it's very readily identified, diagnosed by the radiologist on the mammogram. Consider this case where this woman of 50 years old had very dense breast tissue. The mammograms are normal, even in retrospect. 8 months later, the mammogram is still negative, even with 3D tomosynthesis, which I'll talk about shortly. And now she has a 3.2 centimeter cancer that is readily identified on the ultrasound. And this was a very large interval cancer. Interval cancers that occur in between screens are 18 times more likely to occur with dense breast tissue. And we see cases like this very, very frequently. So this is a woman who has heterogeneously dense breast tissue, and she was undergoing regular screening mammography, but then she got diagnosed as being at high risk for breast cancer and underwent a breast MRI. And this breast MRI shows a very obvious 1.5 centimeter white area that's lighting up, circled in that by the blue circle in her left breast. And this was a cancer that was diagnosed on an ultrasound guided biopsy. In retrospect, the mammogram completely misses it. So we need extra screening tools for women with dense breast tissue. So the difference between mammography and MRI is that mammography detects differences in breast tissue density. And so the tumors have to be large enough or dense enough to be able to permit us to diagnose them. The MRI change is dependent on new vessels. We call this neoangiogenesis. And these new vessels allow the tumor to grow. But because of these new vessels, we can detect them very early with the MRI. So how do we do breast MRI? It's the woman is lying on her stomach with her arms elevated if possible, and the breasts are gently compressed. We have to use an IV injection of gadolinium, which is usually very well tolerated by patients. There has been some concern about accumulation of gadolinium in the body, but there are certain types of agents that reduce that risk significantly. And if there's normal renal function, we will use this every year for high-risk women for 20 to 30 years without any complications. The contrast, the tumors, because the new vessels that they have are very leaky, they allow this accumulation of the gadolinium, which shows up as white on the MRI. So if you look at this these images from the breast MRI, this is before the injection of gadolinium, and you can't see anything in the breast. But when you inject, look what happens to the right breast with this new white mass that shows up quite readily. And this happens really within the first 2 minutes of the injection. We do this subtraction where we subtract the contrast image from the non-contrast image, and we can see very clearly that this looks like a spiculated mass, and it's very readily seen with the MRI. We also use enhancement curves on the MRI to look at how these tumors enhance. And if they enhance very early at 1 to 2 minutes, and then they wash out of their contrast, this is called a type 3 kinetic curve, and it's very suspicious for malignancy. The other types of more benign enhancement or indeterminate, which we call plateau enhancement, can be associated with malignancy, but they're much less likely. So this is an example of a woman who is at very high risk for breast cancer. She has extremely dense breast tissue. She presented because she felt a lump, and that's an important factor. We always have to remember, even with a normal mammogram, you need to get investigated with ultrasound if there's a new lump. And she had, in retrospect, perhaps a small mass that is very seen with great difficulty on the mammogram, but the ultrasound biopsy diagnosed a 1.5 centimeter cancer. Now look at her MRI, and again, you can see quite readily on the left breast that this is the 1.5 centimeter cancer in her left breast. But what we see on the right breast on the other side is a tiny mass that also lights up very clearly on the MRI. And she has bilateral breast cancers, with the right one only seen with the MRI. So this is very helpful to identify the extent of disease with the MRI that we may not see with the breast ultrasound or the mammogram. So there are quite a few studies that look at women who have a personal history of breast cancer, whether we should be doing breast MRI. There are lots of high-risk studies, but this one was from the Maryland group in the United States, and they looked at 249 women who had a past history of breast cancer, and they found that the MRI sensitivity was 85% as compared to the mammogram, which had a sensitivity of only 23%. And none of the cancers were found by mammography in this population. So it's really compelling to show that the MRI can be very helpful. This is a review of 1,521 women and looking at women with a personal history of breast cancer, comparing to other high-risk women for breast cancer, and found that it was actually easier to diagnose breast cancers with fewer false positives in women with a personal history of breast cancer than women who are even at higher risk for breast cancer. And in this study, 13 of the 18 cancers were not seen on mammography. They were false negatives, but were found with MRI. So the problem is we don't have any randomized controlled trials. And you might say, well, why don't we just do MRI in everybody? And so we need more evidence to suggest that doing this in all women who are personal survivors of breast cancer. And currently, the American Society of Clinical Oncology recommends against, and the American Cancer Society don't recommend for or against because of the insufficient data and concerns about cost and morbidity. Here is another example of why, it's so, very easy to diagnose this in women who have a personal history of breast cancer. This woman had a prior left breast cancer. So one of the ways that have been suggested that we may be able to improve access to MRI, because there's a real lack of availability, particularly in Canada, is to do a shortened breast MRI with fewer post-contrast images. So instead of having a 25-minute typical breast MRI with a woman having to lie, without moving for 25 minutes, we could do this in 3 minutes. And it's been shown by several studies to have an accuracy that's similar to standard MRI. So we actually did a prospective randomized controlled trial at the Ottawa Hospital in 200 women. 100 were randomized to mammography and the other 104 were randomized to MRI. And we found in this study that MRI detected all 6 cancers in 104 women who had the abbreviated MRI with a very high cancer detection rate of 48 per 1,000, which is similar to high-risk screening. There were more breast biopsies, so 18% of women who had the MRI had to have a further investigation, but 26% of them yielded breast cancer. And there was no difference in anxiety for women who underwent breast MRI or despite having more breast biopsies. And here are some examples. This is a young 38-year-old woman who had had a right breast cancer. This is her left mammogram, which was reported as normal. And this is her MRI showing a 7-centimeter invasive cancer that was completely missed on the mammogram. Here is another woman who had a previous right breast cancer and a normal mammogram. And she has a 1.5 centimeter invasive cancer in the left breast. So MRI is very, very useful. And we need to be able to provide greater access to MRI to women who are personal history of breast cancer. Well, what about ultrasound? Ultrasound is much more available in Canada, and we use it to diagnose, identify lesions and to perform breast biopsy, but we also do it to screen women who are at a higher risk of breast cancer or to offer supplemental screening for women with dense breast tissue. So we can do handheld ultrasound, or we can do automated breast ultrasound where a less qualified technologist can use this automated machine to generate the images. It has the benefit of less training for the technologist, but it has a downstream negative impact where it requires more ultrasound for a radiologist to supervise and perform the ultrasound and then to do a breast biopsy. So most centers are offering handheld ultrasound, although there are some that are offering automated breast ultrasound. Now, here is an example from our center of a woman with extremely dense breast tissue. She had had a prior left breast cancer. You can see there's a staple in the left breast, and the mammograms are completely normal, but we did an ultrasound that same day, and on the right side, she has an invasive cancer that was completely hidden by the dense breast tissue on the mammogram. And this is a real success. Again, another early diagnosis for this woman with an expected survival of 100%. So what are the supplemental screening strategies for dense breast? We can do ultrasound, and these are for average risk women. Tomosynthesis, both of those increase the cancers by about 2 to 3 per thousand. Breast MRI by far is the best, where it increases cancer detection by 14 to 20 per thousand. And contrast enhanced mammography is a new tool that I'll show you a few images that also increase the cancer detection rate similar to breast MRI. There's another nuclear medicine study that called the CESTAMIBI, which increases cancer detection rate by more than ultrasound and tomosynthesis, but it takes 40 minutes and has a high radiation dose, so it's not recommended for screening strategy. So if you look at the cancer yield for different imaging methods for high-risk women, this is based on a high-risk study in Germany. You can see that mammograms have the lowest cancer detection rate. If you add ultrasound, you add another 2 to 3 per thousand. And if you add MRI, you can see that the best cancer detection rate is 16 per thousand. And that's the basis why we screen women who are at high risk for breast cancer with MRI and mammography. You can see that adding ultrasound doesn't give any benefit. So we don't add ultrasound when we're doing MRI. Now, if you look at the average risk women with dense breast tissue, you can see that the similar findings. MRI has the highest yield for cancer detection rate that's higher than adding ultrasound or even contrast enhanced mammography or tomosynthesis or even annual screening mammography. So we really have the gold standard being MRI as the best tool to add up to find cancers earlier. But supplemental ultrasound is another tool that is available. And as I said, we can use it. The problem is that it has a high number of false positives. And in the first round of screening, after we do an ultrasound, about 3% of women are recommended for biopsy and only 2 to 30% are positive for cancer. It does improve over subsequent rounds where you get fewer false positives when you have more studies to compare with. So if you're going to screen with ultrasound, you need to do it regularly, and it certainly has a way to help improve with cancer detection in women with dense breast tissue. Contrast enhanced mammography is a new technique that I mentioned, which also requires IV contrast injection. This is an iodine containing substance, that compound that is just the same as we use for a CAT scan. And here's an example of a woman with dense breast tissue, no ability to identify the cancer. And you can see that the contrast enhanced mammography identifies a very small cancer right in the axillary tail of the breast. The sensitivity of contrast enhanced mammography is 88% compared to the mammography of 50%. There is a small likelihood of getting a contrast reaction. That's an allergic reaction to the injection. It's only about 1.7%, and most of these are mild, but it is one of the harms that we have to be aware of. And here is another example of a woman with dense breast tissue where we can see much easier with the contrast enhanced mammography, this small 1 centimeter cancer. Now, tomosynthesis is another type of screening that is becoming more and more common. And in Canada. It's a type of 3D mammogram. We use the mammography technique. It only takes a few seconds more to obtain the images, and it's done with the same compression as you would with a mammogram. Some women say maybe it's a little less compression, so maybe a little bit easier to tolerate, and it uses a similar radiation exposure. So this mammogram allows us to see much better because it reduces a lot of overlapping tissues. And this is an example of a very subtle area that's shown with the red arrows on the 2D mammogram. And when you do the tomosynthesis, which is the 3D mammogram, you can see that this allows us very easily to identify a cancer in that dense breast tissue. This was a small cancer found on ultrasound. It reduces the false positives, and it increases the accuracy of the mammograms. And so more and more we are really using tomosynthesis as the better mammogram. And there are studies that show that for diagnosis, tomosynthesis increases the sensitivity of the mammogram. And in screening, it also increases the cancer detection rate as compared to regular 2D mammograms. The most important thing, I think, is that we also reduce the false positive rates. And this is especially good because they're too high in Canada and in North America. So what happens after you have an abnormal breast MRI or even a contrast-enhanced mammography or tomosynthesis? We do a targeted ultrasound directed to the abnormality where we saw that abnormality on the imaging. And this may follow a previously normal breast ultrasound, but we're doing it now targeted to where we know the abnormality is. And if we see a corresponding abnormality on the ultrasound, it allows us to do a biopsy. If we don't see an abnormality on the ultrasound, then we need to do an MR breast biopsy. So let's talk about breast biopsy. They can be guided by ultrasound, mammography, or MRI. They're really what we call minimally invasive. They use local anesthetic. They should not be painful. And if they are painful, you need to let the radiologist know I need more local anesthetic. And it's very rare that it can't be dealt with good technique. It's a very small needle. We take about 4 or 6 samples, and only 30 to 40% of biopsies actually give us a diagnosis of cancer. We expect that 60% of the biopsies are benign, and that's the standard because we have to do the biopsy to determine whether it's cancer or not. Many patients are very afraid of biopsies, and I'm sure as many of you have already experienced, it's not a very difficult experience. Most of you have found it was quite a bit better than you expected. And many patients tell me, oh, that was better than going to the dentist. So no offense to the dentist in the audience. So ultrasound guided biopsy, as I said, is minimally invasive. We use that small needle with local anesthetic, and we acquire these small worms of tissue that are very accurate for diagnosing breast cancer. The pathologist takes a look and has a 95% accuracy for this. We can do the guided biopsies using the mammogram. We can do it, it's called a stereotactic technique, where we use the mammogram to guide our needle, and they can be with you lying on your stomach with the radiologist under the table doing the biopsy, or they can be done as an upright, where we have you sitting upright and we do the biopsy from that position, all with local anesthetic, or with you lying on your side. So there's many different ways to do this kind of biopsy, again, very accurately. MR biopsy is the last type of breast image biopsy that we do. It's done in the magnet of the MRI with you lying on the woman lying on her stomach, and we approach it from the side through this open grid where we put the needle in. Again, using local anesthetic. Again, it should be painless with local anesthetic. This is done when we can't find the abnormality with ultrasound, and we have to rely only on the MRI to diagnose the breast cancer. So that's the summary for biopsies. I just want to focus in the last little bit before I get to your questions is how do we image after a mastectomy? And this question comes up a lot. When you have had a mastectomy and no reconstruction, there is no screening recommendation for women who've had a mastectomy. We only rely on the clinical breast exam because it's essentially, there's no breast tissue to really hide the cancer, and they're usually very readily detected by clinical exam. If there's been an implant reconstruction, either saline or silicone implant, we typically do not do screening, but there's an increasing trend to do implants in front of the pectoralis muscle, and these women may need breast MRI for screening. Autologous reconstruction, where you've had the mastectomy and then a reconstruction with a part of your body, usually a tram or a deep flap, it's controversial. There's not a lot of evidence, but we believe many women may benefit from screening mammography because the deep tissues may not be felt by clinical breast exam. And this is a picture of a woman who's had a tram flap reconstruction, and you can see that there's quite a lot of fatty tissue. So a recurrence close to the chest wall may not be felt by clinical breast exam, but may be readily identified with a mammogram. Now, what about implants that have been done? And you may have heard of this breast implant-associated anaplastic large cell lymphoma. And this is a type of lymphoma. It's a cancer of the lymph tissue, which occurs in the capsule surrounding the implant. And this is with saline or silicone implants that are textured, and it can occur from 8 years or longer after the implantation to diagnosis. Typically, it presents as a fluid collection around the implant, rarely with a solid mass. And it usually has an excellent prognosis, where just removing the fibrous capsule and removing the breast implant can be all that's required. In Canada, or in Ontario, in the last 10 years, there have been 33 cases identified. The textured implants were stopped being used 2 years ago, but there will be more cases diagnosed. And classic presentation is enlargement of the breast or tenderness, on average 8 to 10 years after. And you can see this is a woman who has just an enlarging breast, and this was the implant removed with the lymphoma involved. This is an example from our center with a 35-year-old who had painful enlargement of the right breast 8 years after bilateral breast augmentation surgery. And you can see all the white around the implant is the fluid around the implant. And this was diagnosed with an ultrasound aspiration of the fluid that diagnosed the implant associated large cell lymphoma. And this was removed, and she has had an excellent outcome. So do we actually recommend surveillance in women with textured implants? It's not recommended by Health Canada due to very low incidence, and there's no indication to perform surveillance mastectomy with implant reconstruction at this point in time. So let's end with some guidelines. So what do the American College of Radiology recommend? They recommend for anyone with a personal history of breast cancer and dense breast tissue, or anyone diagnosed under the age of 50, that annual surveillance with breast MRI is recommended in addition to annual mammography. The digital breast tomosynthesis they have insufficient evidence to recommend the use. But, and they also recommend ultrasound for women who could qualify but can't undergo breast MRI for some other reasons. And for women should be continuing to have supplemental screening with mammography. This is a very busy slide, but just to show you that it's not uniformly recommended. And the ASCO and the National Comprehensive Cancer Network at this point does not recommend MRI or ultrasound. The American Society of Breast Surgeons recommend annual mammography plus MRI, and if they have dense breast or are diagnosed under 50 years of age. So what should you be doing? Every year, there should be screening mammography, so long as you have a life expectancy of 7 years or greater. If you have dense breast tissue, you should consider adding supplemental MRI screening every 1 to 2 years. And if MRI is not available, supplemental breast ultrasound every 1 to 2 years. At the Ottawa Hospital, we also have capacity issues, and we have come up with our guidelines. We recommend annual screening without stopping. And for women who are diagnosed under the age of 50 with dense breast tissue, we offer breast MRI every 2 years up until age 50 years. And for women older than 50 years with dense breast tissue, we add, we change that to screening breast ultrasound because of our capacity issues with MRI. And we stop that supplemental screening at age 69. If they're undergoing breast MRI, there's no value to adding screening breast ultrasound. So diagrammatically, this is what we do at the Ottawa Hospital and in the region. MRI plus MRI and mammography plus ultrasound for 50 to 69, and mammography continuing on every year for 69 years and older. If we have a concern about metastatic disease, breast cancer typically metastasizes most commonly to the brain, to the lung, to liver, and to bone. How do we evaluate for metastatic disease? We do not do this routinely if there are no symptoms. So if we have no symptoms of bone pain or abnormal abdominal pain or chest cough, pain, or breathlessness, we don't recommend extra investigation. But if there are symptoms of metastatic disease, we would do, for localized bone pain, a nuclear medicine bone scan. For abnormal liver function test, abdominal pain or symptoms, an abdominal CT. And any chest symptoms, we would do a chest CT. PET CT may be done for locally advanced cancers to look for metastatic disease anywhere in the body. And brain MRI or contrast enhanced head CT are done for suspected brain metastases, but it's not routinely done. So if I can summarize, having a personal history of breast cancer can lead to a very long life expectancy. But we do know there's a higher risk of developing a new or recurrent breast cancer in a person with personal history of breast cancer. So screening mammography every year is recommended as long as you're in good health. And if you have dense breast tissue, you should be going for supplemental screening, MRI or ultrasound. What can you do? I think really make sure that you have a regular screening mammogram. Be aware of your breast tissue density. If you're not aware, it should be available on every report, and your doctor, family physician, or oncologist should be able to provide that to you. If you do have dense breast tissue, consider request for supplemental screening. And you need to be willing to undergo more biopsies because of the higher cancer detection rate. But any new symptom, whether it's a lump, a skin change, nipple, inversion, water or bloody nipple discharge, or focal breast pain, you really need to get that investigated with a diagnostic breast ultrasound, not a screening study. So I'll leave you with these 2 QR codes to provide more information. You can just scan these to get more information, and I'm very happy to take more questions. Thank you very much.
Wow, thank you so much, Dr. Seeley, for that excellent presentation. That's wonderful. I'm going to give you a question that was submitted in advance, and then we'll start taking a few more that have been coming in. You've answered a lot of the questions that have been coming in. So one of the questions that was submitted to us was, should there be different follow-up screening for different types of breast cancer? For example, triple negative breast cancer or HR positive, HER positive, would they be screened differently?
Yeah, it's a great question. So we know that women who have high-grade invasive cancers and triple negative cancers, they're a more aggressive tumor, And so they can metastasize earlier, or they can recur. There's currently no recommendations for any different screening, but I think it's very, very important to be aware of any changes or any potential symptoms of a recurrence, like a new lump or any symptoms of metastatic disease. So no additional screening based on what I've said is really that it should be annual mammography. And if they're under the age of 50 with dense breast tissue, adding MRI, or if they have dense breast tissue, adding MRI up until their age 69.
Okay.
Or anything specific for, could you speak to inflammatory? Sorry, there was a question that we should have added in there around inflammatory as well. Is it the same, or
It's
would
the
there be anything
same
special?
thing.
Okay.
Yeah. There's no special different screening regimens currently recommended based on tumor histology, but we recognize that it's more of a difficult one. But I will say this again: early stage diagnosis of triple negative or high grade tumor have the same prognosis if they're diagnosed at an early stage. So I think we really want to make sure we be aware and keep trying to diagnose any recurrence or a new breast cancer at an early stage.
I have a question regarding patients who ask, how do I know I have dense breast? Like, are radiologists letting individuals know? Is that common standard of care to tell a woman that she has dense breast? I think earlier that wasn't being done, correct?
So you're absolutely right. And it's so variable depending on the province you live in the country. And I know Quebec, the breast tissue density notification is put in the report, but it's not being communicated to patients directly. But it is in the report. It depends. In British Columbia, for example, women's breast tissue density is being communicated to the patients, as well as being in the report. In Ontario, women who have the most dense breast tissue they get their density by letter from the Ontario Breast Screening Program, but the other densities do not. And when we're talking about women with a personal history of breast cancer, they're automatically not in any screening program. So it's a very different kind of policy, and it depends on where they have their imaging being done. It is a recommendation by the Canadian Association of Radiologists and Canadian Society of Breast Imaging that breast tissue density be put in every report. So it should be available, but I can't, it's so dependent on geography. And what we would really like is for everyone to be aware of their breast tissue density.
So I would say that for those of us who are on this webinar, that we ask that question when we get our mammograms. I think if we advocate for ourselves and say, ask the question, that's at least one step further that you can, personalize your quality of care.
I completely agree with you, Kathy. And I think it's so important to know your breast tissue density, because you know then about whether you have that higher risk factor. And you also know if the mammogram can miss your cancer, because, what we don't want is a false reassurance from the mammogram, saying, well, it was normal, but people aren't aware of their density. So it's very important. And I think that's something that I would like to empower everybody on the call, is to be aware of their own breast tissue density. You should know it just like you know whether you have a mother with breast cancer.
Excellent. Jen, would you like to ask a question before we
Yes, so we have
finish?
more than we can answer for sure. So we may have to do a questions and experts series here. We might have to get you back, Dr. Seeley. But I think maybe to close, and you answered quite a few throughout the presentation, as Kathy said, but something that you highlighted was really the need for MRI screening. And a great question that came in saying, based on the guidelines that you've shared, do you have any suggestions on how to approach your care team to advocate for MRI instead of mammography, if that really is is what's needed in terms of that surveillance, especially if you're known to have dense breasts. Any advice on that?
Yeah, I mean, my goal is always to provide information to empower everyone to know why. I think that's the first step. Why do we do this? So, and I do want to make sure that everyone is aware that we want to start with a mammogram. It's the only way to tell breast tissue density. So even if, and this comes up a lot with the oncologist and some patients who said, well, the mammogram missed my cancer on the mammogram, you know, so why should I bother? It's very different. After treatment, we know that the mammogram, the density may change, and we may be able to very successfully identify a recurrence in a woman whose first cancer was missed on the mammogram. But how to empower them? If they have dense breast tissue, they should be asking if they can have a breast MRI. They would feel more, you'd feel more comfortable. You know that the evidence is out there for this, and this is how we have to shape our changes in policy. We need to have greater advocacy for more breast MRI access in Canada. We are very much behind in this, and we need to advocate. So it starts by just having a conversation. And I will say that a lot of family physicians aren't aware of this either. So, you know, I may be speaking to you, and you may be the first one to tell your family physician. So I think you have a role to share that with them as well.
Well,
Thank you.
Thank you.
Before, Kathy, we turn it back to you to wrap it up, I just wanted to also mention to the audience participating that Dr. Seeley has agreed to review an advocacy guide that CBCN is developing around screening after breast cancer. So we should have that out in the next couple of weeks. Everyone who registered for the webinar will receive a link to that. So Dr. Seeley will be able to continue to share her knowledge with you and hopefully answer some additional questions. Kathy, over to you for closing.
Well, first, I want to thank you again, Dr. Seeley. This has been an exceptional, impressive presentation, and we're going to need to do something about all the overwhelming, questions that we've had. So thank you again. And that concludes our time for today's session. Thank you again for your questions and for joining us. And thank you again for this great opportunity, Dr. Seeley. We want to thank Bayer, our sponsor for the session today, who made this possible. And thank you everyone again for joining us. We look forward to connecting on another virtual session in the future, and have a good evening, everyone.